ഫെസി, ഡോക്ടർ ഫെസി.
ഫെസി സാറിനെ കാണുന്നില്ലല്ലോ. കുഞ്ഞുമൊയ്തീൻ സാർ വന്നാൽ നമുക്ക് വി ക്യാൻ സ്റ്റാർട്ട്. ഫെസി സാർ വന്നോ? ഓക്കെ, നോ പ്രോബ്ലം. അല്ല, വെബിനാറിനല്ലേ ഉള്ളൂ. സോറി, പാനൽ ഡിസ്കഷൻ.
ഹാൻഡ് റൈസ് ചെയ്തിട്ടുണ്ട്.
ഓക്കെ, സുഭാഷ് ഈസ് ഹിയർ. ഹായ്, ഗുഡ് ഈവനിങ് സുഭാഷ്, വെൽക്കം.
Good evening, sir.
കുഞ്ഞുമൊയ്തീൻ സാറ് സ്റ്റാർട്ട് ചെയ്യാമോ?
സ്റ്റാർട്ട് ചെയ്തോളൂ.
സാറേ, ഗുഡ് ഈവനിങ് സാർ.
ഗുഡ് ഈവനിങ്. സുഭാഷ്.
ഗുഡ് ഈവനിങ് സാർ. എവിടെയാ?
ഞാൻ തിരിച്ചെത്തി.
ഓക്കെ. പുറപ്പെട്ടു. അരമണിക്കൂർ മുന്നേ പുറപ്പെട്ടു.
അതെ, അരമണിക്കൂർ മുമ്പേ പുറപ്പെട്ടു.
നമ്മൾ ലൈവ് ആണോ? അല്ലല്ലോ,
ലൈവ് ആയിരിക്കണം. അതിൽ കാണിക്കണ്ടാവല്ലോ. അവിടെ എവിടെയെങ്കിലും എഴുതി കാണിക്കണ്ടാവും. ലൈവാണ് കേട്ടോ. ലൈവാണ്. യൂട്യൂബിലും ലൈവാണ്.
അപ്പൊ നമുക്ക് സ്റ്റാർട്ട് ചെയ്തേക്കാം അല്ലേ? കെഫോഗിന്റെ വെബിനാർ. അജിത്.
ഹലോ
സർ. ഗുഡ് ഈവനിങ് സർ.
കേൾക്കുന്നുണ്ടോ?
ഫെസി സാറെ വെൽക്കം. കേൾക്കുന്നുണ്ട്.
എന്റെ കമ്പ്യൂട്ടറില് വീഡിയോ ഓൺ ആവണില്ല. അതാണ്, ഞാൻ കുറച്ചു നേരമായിട്ട് ഓൺ ആയിരുന്നു, പക്ഷെ സൗണ്ടും കിട്ടുന്നില്ല.
എല്ലാവർക്കും ഓക്കെയാണ്.
സൗണ്ട് ഉണ്ട്, വീഡിയോ ഓൺ ആയിട്ടില്ല.
അല്ല, അത് ഞാൻ ഇതിന്നാണ് മൊബൈലിൽ നിന്ന് ജോയിൻ ചെയ്തപ്പോഴാ.
മൊബൈലിൽ നിന്ന്, പക്ഷെ വീഡിയോ ഓൺ ആയിട്ടില്ല.
വീഡിയോ വരും, അത് ഞാൻ ഓഫ് ചെയ്തോണ്ടാ. അതല്ല, എന്റെ കമ്പ്യൂട്ടറിൽ അത് പറ്റണില്ല, എന്തോ പ്രശ്നം പറ്റിയിട്ടുണ്ട്.
രാത്രി ഫ്രിഡ്ജിൽ വെച്ചാ.
Shall we start, sir?
Yeah.
Good evening, one and all. Respected seniors, office bearers, presidents of respective societies, senior delegates, and my dear friends. PCOS is something that every gynecologist deals with day in and day out in their practice. So hence today, on the 18th part of the series of Kfog Edge, we have the topic PCOS with infertility, optimizing the outcome, which is brought to you by the Reproductive Health Committee in association with the different societies of Cochin, Thrissur, Malnad, Angamali, and Palakkad. First of all, let's have a silent prayer, and then we shall start the webinar. Thank you. I would like to invite Reggie sir first. He is the chairperson of the Reproductive Health Committee of Kfog. Over to you, sir.
Good evening, and welcome you all for this Kfog Edge webinar series number 18. I would like to, I think we are coming to an end of Dr. Kunyumoidin sir's as president of Kfog, and we had a very fruitful time throughout the year. So this is the 18th webinar, and most of us, this was all the webinars. Actually, I have conducted 4 to 5 webinars, and all the webinars we tried to involve all the societies of Kfog, all the societies, and this is the last of the series. And we have, as Dr. Ajit has told, we have Mallanadu, Palakkad, Thrissur, Cochin, and Angamali society. So we have our panelists from each society. So we have made sure that each society get involved in the webinar, and a very, very relevant topic in infertility or reproductive medicine. So I would like to thank specially Dr. Kunjamuddin sir, our president, and our own lovable secretary, that is Subhash Malaya, for coming and gracing the occasion. So Kunjamuddin sir and Subhash Malaya doesn't need any introduction. So I would like to welcome Kunjamuddin sir to inaugurate this meeting and say a few words on this Kfog Edge webinar. Thank you, sir. Over to you.
Dear Dr. Reggie Mohan, the chairperson of Reproductive Health Committee, Kfog Secretary General Dr. Subhash, Foxy past Vice President Dr. Fessi, Dr. Sujitra ma'am, she has not joined, I think, the coordinator of this entire Kfog Edge webinar series. Dear faculties, the presidents and secretaries of the 5 participating societies in the mid-zone, the Dr. Ajit, the MOC for today's webinar. At the outset, I really appreciate the efforts of Dr. G. Mohan, who has taken all the efforts to complete all 3 webinars which have been assigned to him during the past 1 year. And almost all the webinars which have been assigned to him have been conducted with very good involvement from all the society, faculty from all the society. And all the past 2 webinars were exceptionally good, and it was very well taken by all the delegates who have attended. Today, in the coming 2-3 days, because we have only around 10 more days to go for AKCOG. So you can see a lot of the webinars which will be happening in the coming days, back to back. All the committees who have not completed their third ones. For example, on Saturday, you are going to have 2 or 3 EDGE webinars on the same day. The adolescent committee and the research committee, they'll be conducting back to back. So the idea is that, all the webinars have been crafted with a definitive thought process in mind, so that we'll be having this program organized so that all the practicing gynecologists, not only the subspecialists in infertility, oncology, or endoscopies, and not like that. So all the practicing gynecologists will have an updated information about all the subspecialty topics. And because all of us deal with all the types of patients, at least at the first instance, before referring them to the subspecialty specialists. So that is the idea when we were crafting, myself and Subhash, when we were sitting together to crafting the topics, the themes for each of the committees. So this year, I'm so happy that all the committee chairpersons have supported us in a long way to have all these webinars happening on time and without much fail. So based on all these activities for the chairpersons, I think I request all the chairpersons to submit their reports to the Secretary General on time to be considered for the Best Committee Award as well. So with these few words, I would like to emphasize the importance of polycystic ovary, which is a disease. It is a very common diagnosis which patients very often tell as their complaint. When often we ask the patient, what is your complaint? Are your cycles regular? They always say that I am having PCO. So this is one thing they tell, a diagnosis which they tell as their complaint. So that much importance it is there for the topic for the specialists as well as for the common public as well. So today's topic will specifically concentrate the PCO and its infertility management options. And we have a wonderful group of faculty, the panel discussions, and Dr. Rashmi, Dr. Reggie will be moderating a wonderful panel discussion with, we'll have a lot of insights from Dr. Fessi with his lots of vast experience and all the other panel experts. With these few words, I declare this webinar inaugurated. Best wishes.
Thank you, sir. Subhash sir.
Sir, nothing, sir. Sir, at the outset, I would really like to thank you because you are, it's like, we call it two hats or Parila. Sir, you're sitting in three things. You are here, the Reproductive Committee Chair, sir, of KFOG. You are the Secretary of Trivandrum Society, and you are also the Organizing Secretary of AKCOG. I don't know how you are able to laugh, sir, because had it been me about a week prior with three things, I would have been half dead by now. really appreciate your efforts, as your sincere efforts in trying to conduct this webinar, sir. As Dr. Kunjumuddin sir rightly said, sir, you're finishing your third one. It may have been because all of us are busy. There may have been some delay, but that's okay, sir. You've done your level best, and really like to thank you on behalf of all the members of K4G for the wonderful work that you have been doing. And we are looking forward for a wonderful AKCG also, sir. I would like to thank all the president secretaries of Palakkad, Thrissur, Malanadu, Angamali, and Cochin Society. We also have the secretary of Cochin Society right now, Fessi sir, who's got his video back. So really thank all the president secretaries for the wonderful support they've already given us. Also, I would like to thank each and every member of the each society of these mid-zone societies who've actually volunteered and helped us out with this. I would like to thank Ajit also for the same. Of course, I will cannot forget the sponsors for the day for the whole series, that is Astria Life Sciences. I'm really grateful to the whole team of Astria Life Sciences for the wonderful academic support and the grant that they've given us for this webinars. And with this short words, I'm looking forward to meeting all of you at the AKCOG Trivandrum, and let's make it a very memorable one. Thank you, sir. And also would like to thank all the speakers and the participants of the last but not least, all the delegates who have spending their precious time over here. I can see a lot of participants here. I just hope they are not only the students of register. I think they're also outside. I hope they're outsiders also.
Most of them. Thank you,
Hello.
Subhash. Thank you
No, sir.
very much.
Sir, Tamasha ka, sir.
Thank you, Subhash. Thank you very much for the kind words. And is there any? I think I saw Emmy's this thing. Is there Emmy? Emmy is there? Emmy was president of Palakkad Society. Any other presidents or society, this thing for
I'm here,
felicitation?
sir.
Yeah, Emmy. Hi. Hi,
Sir,
Emmy.
Naik sir was also there. Sir, Naik sir was also
Naik sir. I saw Naik sir, but now I can't see his name actually.
Naik sir was
Emmy,
also
Emmy, a few words.
Yes, sir. Good evening. Thank you for this opportunity. I think this
Okay.
is the last webinar where I'll be the president of POC. So that's a wonderful activity of Kfog for this year 24-25. This Kfog webinar series are very useful actually. This is a very novel and innovative idea. Thank you, Kumnyamudin sir, Subhash sir for coordinating and all those involved in this.
Thank you, Dr. Emmy.
and
Thank you,
also
Dr. Emmy.
sorry, sir. We also have Hema Warrior madam also here, sir, and Sadeep madam is Sadeep Pillai madam is also joined, sir. Sadeep Pillai madam, Radhamani madam, and a lot of the seniors also here, sir. So
Thank
nice
you.
to see seniors also here, sir.
I think welcome all. Welcome all. Sujitra madam, our coordinator for this webinar Edge series, ma'am, and our next president also, Sujitra madam. Welcome you for this webinar, ma'am.
Thank you, Reggie.
Kindly bless us.
All my good wishes for this program. The Kfog webinars have been wonderful, and it has already, apart from giving knowledge, it has brought us all together. People from all the ends of the states have come together. We have come to know each other, see each other, and listen to each other. So all the best. So hats off to Kunjumuddin, Dr.
Thank you, madam. Thank you very much. Thank you. We'll meet in AKCOG Trivandrum. Naik sir is there? Chandrasekhar Naik sir, Malanad Society.
Yes, sir. Yes, sir.
Say a few words, sir.
On the behalf of Malanadu Society, all the best, sir, for this webinar series. And I wish all the best for the reproductive health committee who
Voice is gone. I think the audio is broken. It's not heard properly. Thank you, Naik sir. I think that's all.
I lost.
Yes, sir. Signal is very weak, I think. Yeah, yes, sir.
Okay, go ahead.
Yes, sir.
Go ahead.
Can see you.
Go ahead, sir. Thanks for giving an opportunity for in this webinar participation. Thank you, sir. All the
Thank
best,
you, sir.
Riji sir and Rashmi madam.
Fessi sir, our Cochin Society Secretary. Dr. Fessi. Fessi ma'am. Fessi sir.
Good evening to all. I think it is as you all aware, this is a wonderful initiative. I think even though it started first in COVID time, this webinars, it is found to be very useful, not only for the postgraduates, but for the practicing doctors who are busy in their practice. They can find few time so that they can update their knowledge. And so let me congratulate for Kfog, especially President Kunjumoideen, Secretary Subhash, and the Reproductive Medicine Committee, Chairperson Reggie, for taking this initiative and completing the successful webinars, and wishing all the best for their future endeavor also. Thank you. Thank you for involving Cochin Society in this.
Thank you. Thank you very much. Thank you. So over to Ajit, sir. Ajit.
Yes, sir. So now we'll move on to the first session, which is ovulation induction in PCOS. We have Dr. Rashmi.
Sorry, I didn't introduce Ajit. Ajit needs, he's the consultant gynecologist in GEM Hospital, Palakkad, Simar Hospital, Cochin, visiting consultant, Simar Hospital, Cochin, finished his fellowship in Simar, Edapal Hospitals, and now he's a consultant. So Ajit is our master of ceremony, and he will be managing the...
His father, Krishnarao sir, has also joined the program, sir. I just checked.
Thank you, sir. Thank you, sir, for joining. Ajit, please.
Yes, thank you, sir. Thank you, sir, for the introduction. We have Dr. Rashmi with the session Ovulation Induction in PCOS. Dr. Rashmi has completed a fellowship in reproductive medicine, fellowship in minimal access surgery, and is presently working as the in-charge and senior consultant at the Department of Reproductive Medicine, Kinder Women's Hospital and Fertility Center, Chertala and Agapi. He's a person who's got multiple awards, including gold medalist and Prabhati Mishra Award for Best Outgoing PG, Berhampur University, multiple awards in endoscopy, as well as ISAR Youth Icon Award. He's also held multiple positions, including the treasurer of COGS, executive committee member of COGS. She's been a faculty at national and state conferences, and she's also had multiple publications. So welcoming Dr. Rashmi. Over to you, Dr. Rashmi.
Thank you, Dr. Ajit, for your kind introduction. So at the outset, let me thank Kfog President Kunjumoideen sir, Secretary Subhash, Foxy Vice President Fessi sir, Kfog Reproductive Health Chairperson Reggie sir, and Sujitra Madam for this opportunity. So greetings from Cochin Society. Hope we all will meet at AKCOG in a week. Okay, so moving on to my topic per se. PCOS, ovulation induction in PCOS. As we all know, that PCOS is the most common endocrine disorder in reproductive age group women. Just a few slides to brush up on the menstrual cycle and oogenesis. So, menstrual cycle is divided into follicular and luteal phase, which happens with the control of hypothalamo, pituitary, and ovarian axis hormones. A follicle recruitment takes in the first 1 to 4 days, followed by selection, which takes place in the 5 to 7 days, and the dominance happens by around day 8. What happens? What's the relationship between LH and ovulation? We all know that after LH surge, at 36 hours precisely, ovulation happens. Peak happens 24 hours past LH surge, and once the peak occurs, in 10 to 12 hours, ovulation occurs. So, how ovulation occurs is with a sharp surge in LH with a simultaneous increase in FSH. Meiosis 1 resumes, that is the oocyte, and the surrounding cumulus breaks away and are extruded, and our ovum passes into the oviduct. So, coming to the requirement of ovulation induction. Does all women entering our clinic require ovulation induction? Who require ovulation inductions? The broad indications are WHO group 2 having anovulatory cycles, that is a PCO group, those with luteal phase defect, unexplained infertility, those undergoing ART, IUI, and in poor responders. So we all know that one of the most common cause of female infertility is ovulatory disorder, and out of the ovulatory disorders, PCOS predominate. This is the WHO classification of anovulation. WHO has divided anovulation into 3 groups. Group 1 is hypogonadotropic hypogonadism, that is the women with hypothalamo-pituitary failure, which constitutes around 10%. The majority, 85%, is normogonadotropic normoestrogenic, that is PCOS, and 5% is hypergonadotropic hypoestrogenic, that is ovarian failure. Now, polycystic ovarian syndrome, coming to the topic per se, it is the most common endocrine disorder in women with a prevalence of around 10 to 15%. It is usually first identified during the early reproductive years, post-menarche, when a girl has excessively irregular cycles. The clinical expression varies from person to person, but it commonly includes oligo or anovulation, hyperandrogenism. It can be clinical or biochemical, and the presence of polycystic ovaries. We still follow the revised Rotterdam 2003 criteria when 2 of the 3 has to be present, with excluding the other endocrinopathies. So polycystic ovarian syndrome is rightly called a disease which starts in the womb and lasts till the woman is in the tomb. As I've already told, it has got multitude of symptoms. It has reproductive disorders and metabolic disorders. In younger age girls or in a woman with reproductive age group, they usually come to us with menstrual disorders, hirsutism, for contraception, sexual health, and infertility. And as the woman ages in the perimenopausal and the menopausal age group, pregnancy complications, the quality of life, type 2 diabetes mellitus, cardiovascular diseases are increased in this group of women with higher prevalence of CAD and stroke, and a suspected cancer risk also. So these are the latest ASRM 2023 recommendations on diagnosis. What is ovulatory dysfunction? They have described ovulatory dysfunction, hyperandrogenism, and the ultrasound features. Ovulatory disorders can be a woman with cycles less than 21 days or more than 35 days or less than 8 cycles per year. Hyperandrogenism can be biochemical or clinical. Biochemical, the main hormones that we test for are testosterone and free testosterone. And they have also specified how we have to test the testosterone. It is by using tandem mass spectrometry. And if the diagnosis is inconclusive, we can use androstenedione or DHEAS also for diagnosis. Clinical criteria are hirsutism using the modified Fermat-Galway scoring system, hair loss using Ludwig or Olsen visual scales, or a woman presenting with severe acne. Now, coming to the ultrasound and polycystic ovarian morphology. For the follicle excess criteria are follicle number per ovary and follicle number per section. Outer follicle number per ovary, with the acronym of FNPO and FNPS, FNPO has been given more importance than FNPS. And ovarian volume are accurate markers for diagnosis in adults. And TVS is the preferred modality wherever possible. FNPO more than or equal to 20 in at least one ovary, ovarian volume of more than or equal to 10 ml, and FNPS of more than or equal to 10 in one ovary is usually considered the threshold. So this is also according to ASRM. So a lot of controversy has been going on recently whether we have to use AMH in all infertile patients. AMH can be used in defining PCOM in adults, but not in adolescents. But in a patient who is coming with symptoms suggestive of irregular cycles and hyperandrogenism, AMH is not necessary for this diagnosis, and it is not to be used as a single test for diagnosis. So either AMH or ultrasound can be used, but both need not be used. Hope I have made my point very clear here. Now, coming to the types of PCOS. So PCOS have been divided into 4 types. Type A patients will have all 3 symptoms, that is high androgen level, irregular periods, and polycystic ovaries. Type B patients, they'll have normal ovaries with the other 2 symptoms. Type C, regular periods, and type D with normal androgens. These are the types of PCOS. Now, coming to the ovulation induction drugs in PCOS, we can divide that as oral agents and injectables and adjuvants that we commonly use in our clinical practice. Oral agents can be selective estrogen receptor modifiers like clomiphene citrate or tamoxifen. Aromatase inhibitors can be letrozole or anastrozole. Injectables can be HMG or recombinants. Adjuvants that we usually use are metformin, minoxidil, N-acetylcysteine, and dexamethasone. Now, what is the role of ovulation induction here? The role of ovulation induction is to increase the FSH threshold, so which will rescue a follicular cohort before they undergo atresia. Hence, we have more follicles which are entering the pre-ovulatory stage. The method that we choose as clinician should be based on what is the underlying cause of an ovulation, the efficacy, cause, risk, and potential complications. One size fits all does not apply to infertility. We'll have to individualize our treatment, individualize our patients before deciding on the management. Now, we all know that ovulation induction agents are one of the most misused drugs. This should not be used for more than 12 months in a patient's lifetime, and it should be used only for a maximum of 6 months consecutively. So if a patient is not conceiving in 6 months, we should not again repeat what we were doing. We have to look for other causes, or we have to move on to the second line therapies. The goal of ovulation induction is the development of a single dominant follicle. Before ovulation induction, these are the prerequisites. We have to take a proper history and physical examination of both partners. A detailed, comprehensive history has to be taken. Male partner semen analysis. Often we have seen that a woman might be coming to our clinic with after 6 or 8 cycles of ovulation induction, but we won't have a report of semen analysis in our hands. So that is very important. Before we give ovulation-inducing drugs to any patient, just do a semen analysis for the male partner. The relevant blood investigations that we usually recommend are thyroid function test, CBC, RBS, prolactin, not in all patients, only in patients with symptoms of galactorrhea or severe headache. And when diagnosis is to be confirmed, pituitary hormones can be done. Now, coming to our hero in PCOS, that is letrozole. So we were all very concerned till letrozole came back after the initial ban. Let us talk about letrozole. It is an aromatase inhibitor which converts testosterone to estradiol and androstenedione to estrone. So, as an aromatase inhibitor, the aromatase enzyme converts testosterone to estradiol. So, when we give an aromatase inhibitor, this conversion is blocked. So, what happens is estrogen level falls in our body with an androgen level increasing in the body. This negative estrogen level will decrease the feedback on the pituitary, which causes increased FSH. And hence, this will cause our initial, what I told earlier, follicular recruitment, selection, and domination. And accumulation of androgens locally will increase the follicular sensitivity to FSH also. The recommended dose, this is what we do in our routine practice. We give for 5 days, day 3 to day 7 usually. 2.5 mg or 5 mg can be given letrozole or anastrozole of 1 milligram. These are the advantages over clomiphene citrate. It has reduced incidence of multiple gestation, reduced incidence of OHSS. Pregnancy rates are almost similar and reduce adverse effects on endometrial and cervical mucus. So, as I've already told, there were some teratogenic potential concerns in the initially. So, this led to banning of letrozole for around 5 to 8 years. Surveillance studies demonstrated that there was no higher rates of congenital malformation as compared to clomiphene citrate, and the early timing of administration in the cycle reduced the risk of fetal exposure. Now, CC versus letrozole. CC has been there with us for more than 50 to 60 years. So CC has been the first line of treatment with proven efficacy. But letrozole is replacing has already replaced CC as a first line in PCOS patient due to monofollicular ovulation. Letrozole has a shorter half-life of 45 minutes with equal efficacy in ovulation and pregnancy rate. Now, in those patients where the routine letrozole protocol, we are not getting ovulation or we are finding letrozole resistance, these are some of the protocols where studies have been published. But we cannot recommend any of these protocols at present because most studies and RCTs are awaited. Extended letrozole protocol. If a patient does not respond to 5 mg per day for 5 days, letrozole can be given for 7 or 10 days. This study was done in 2022 and published by Zhu et al. In Fertility Sterility, and they showed a 90% ovulation and 30% pregnancy rate with this protocol. Next is a stair-step protocol. So what we usually do is 5 days we give letrozole and we do a scan, a follicular study on day 10 or day 9, and we don't see any follicle. So usually we are forced to cancel the cycle. We are forced to give progesterone and cancel the cycle. So Thomas et al. Published this protocol to avoid cancellation, to cause ovulation in the same cycle. So what is recommended is letrozole 2.5 mg for 5 days. We do a usual scan on 9th or 10th day. We see that no follicles are there. We can increase the dose of letrozole to 5 mg for 5 days. And again, we can repeat the ultrasound after 5 to 7 days after the last dose of letrozole. So what this protocol did is they eliminated the use of progesterone to induce withdrawal bleeding between successive cycles. Now, Mitwali et al. Came with a step-up protocol. In this protocol, the letrozole was administered in step-up doses of 1, 2, 3, 4. Very easy to remember. 1, 2, 3, 4 tablets of letrozole of 2.5 mg daily on 2nd, 3rd, 4th, and 5th menstrual day. This caused multiple follicular development with higher pregnancy. But as I've already told, it was a very small sample size, so more data awaited. Now coming to our age-old clomiphene citrate. I'll be briefing through clomiphene citrate. So this is the most common selective estrogen receptor modifier, ideal dose of 50 to 100 mg from day 2 or 3 for 5 days. Dose more than 150 mg may lead to hypoestrogenic effect, hence not recommended. And CC does not appear to increase the chance of pregnancy in women who are regularly ovulating and failure to conceive after 1 year of unprotected intercourse. So mechanism of action, this causes is an estrogen receptor modifier. So this causes an irreversible inhibition of estrogen receptors at the hypothalamus, which removes the negative feedback of estrogen, induces GnRH and pituitary gonadotropins, and induce follicular development. So during CC, FSH and LH undergo prolonged rise because of the prolonged estrogen receptor depletion. That is, we are extending the FSH window, leading to multifollicular recruitment. So in ovulatory women, usually GnRH pulse frequency increases, while in anovulatory women with CC treatment, GnRH pulse amplitude is increasing. Monitoring of CC cycle is very important. It has to be monitored with a transvaginal ultrasound, a baseline scan on day 2 and 3, followed by day 9 and 10. We have to do routine follicular studies till maturation. So despite high ovulation, we are having a low pregnancy rate in CC, probably due to the anti-estrogenic effect. And we also have concerns regarding the luteal phase defect, and premature LH surge may occur due to supraphysiological estrogen level. And this cannot be used in hypogonadotropic dysfunction. These are the adverse effects usually associated with clomiphene citrate therapy. Okay. Now, clomiphene citrate, as per RCOG guidelines, it should not be used more than 6 cycles continuously and not more than 12 cycles in a lifetime to avoid the risk of possible malignancy. So, good practice guidelines in RCOG and NICE have recommended to use monitoring with ultrasound during CC stimulation. Now, a word about CC failure and CC resistance. CC failure is failure of conception within 6 cycles of ovulatory cycles, that a woman is ovulating with clomiphene citrate, but still she is not conceiving. What are we supposed to do? We have to expand the diagnostic evaluation. We have to exclude other factors and change the overall treatment strategy. CC resistance is failure to occur even with in 3 months with high doses of CC. Usually it occurs in association with insulin resistance in around 20% of women. So, coming to our second line therapy, when should we use gonadotropins? Should we use gonadotropins? If hypothalamic or pituitary dysfunction is detected, or if oral regimens are unsuccessful, injectable gonadotropins can be used. Most common regimens are step up, step down, a few other regimens I'll be just detailing. Step up regimen, we start our treatment with 50 to 75 international unit of either HMG or FSH, and depending on the follicular response, we can give increments of 37.5 units. Step down, we usually start with 150 till a dominant follicle appears, following which we step down the dose of gonadotropins. Step-up protocol for PCOS, usually a low-dose step-up protocol is recommended. When we start with 37.5 to 75 units, we scan on day 7. If there are no response, we increase the dose by 50%. But this protocol requires a lot of patience. Step down protocol, we start with 150, scan on day 4 or day 5. If we get a follicle of more than 10 mm, we can decrease the dose and then do a subsequent follicular study every 3 days till the dominant follicle is around 18 millimeter, when we can give the trigger. Standard protocol is when we keep the dose throughout the stimulation. Use of agonist or antagonists are not recommended in ovulation induction cycles or IUI cycles. HMG or recombinants not having much difference, we can choose based on purity and cost. There's no convincing evidence regarding the probability of conception also. Now, sequential CC gonadotropin theory. So this is therapy. This is a therapy protocol which is a favorite among Indian subcontinent doctors, because we feel that we can get the advantage of gonadotropin without compromising on our pregnancy results. So standard clomiphene citrate therapy followed by low-dose HMG or FSH can be used with around FSH dose of around 75 to 150 units for around 3 days. This treatment is individualized as the same way as a traditional therapy on the basis of transvaginal examination. The sequential therapy is said to be as effective as gonadotropin-only therapy in terms of ovulation induction, satisfactory pregnancy results, and reduced treatment costs. A word about adjuvants, metformin alone or compared with placebo. When compared with placebo, increases the ovulation rate, but it's not used as a first-line drug for ovulation induction. It is said to increase the live birth rate and reduces the miscarriage rate, but at present, recommendation is in women with impaired GTT or increased fasting insulin level. N-acetylcysteine is a mucolytic agent which is effective in inducing and augmenting ovulation along with ovulation-inducing drugs at a dose of 1200 milligram per day. It inhibits oxidative stress and improves peripheral insulin. Myonistal, based on a study by Zheng et al. 2017, it can be used in women with PCOS, especially those who cannot tolerate metformin, in women who's having insulin resistance. So this can be considered in women who's having severe gastrointestinal side effects with metformin. Of course, PCOS pregnancies. We have induced ovulation. A woman has become pregnant, but we have to counsel beforehand itself that this is going to be a high-risk pregnancy. We have to expect all these high risks. There is higher risk of miscarriages, gestational diabetes, hypertension, preeclampsia, cervical incompetence, IUGR, SGA babies, preterm deliveries, and cesarean section. IUI with ovulation induction. I don't think I have the time for this. I'll just be going very fast through these slides. So IUI when planned, has to be coupled with ovarian stimulation because it provides more number of oocytes. We can time HCG induction, and it corrects the subtle endocrinopathies, which impairs ovulation and implantation. These are the few studies when letrozole was associated with an increased clinical pregnancy rate compared to CC and decreased rate of multiple pregnancy. And shifting from unifollicular to bifollicular ovulation in IUI cycle increase the pregnancy rate by 3.4-fold. Optimum stimulation is 2 to 3 follicles of 18 to 19 mm. This is for IUI cycles, not for our ovulation induction. An endometrium of 8 to 14 with a trilaminar pattern and IUI timed at 36 to 40 hours after the HCG injection. So this is the ASRM 2023 flowchart on PCOS management in infertility. So we diagnose PCOS, optimize preconception, health and lifestyle, first-line medical treatment, of course, letrozole, increasing dose as required, can consider CC with metformin or without metformin as a alternative to letrozole. But nowadays, I think letrozole as a first-line treatment is what we should follow. If the patient is ovulating but not conceiving, then we have to change our strategy of management. The second-line medical management is gonadotropin with ultrasound monitoring, adjusting dose as required. In place of gonadotropins, considering facilities and expertise, laparoscopic ovarian drilling should also be kept in mind. And if the patient is still not conceiving, the third line of management, IVF, should be counseled for these patients. Now, coming to the take-home points. These are directly from ASRM 2023 guidelines. Reassure PCOS patients that pregnancy can often be successful, either naturally or with assistance. Letrozole should be the first-line pharmacological agent for ovulation induction. No evidence of increased teratogenicity when compared to others. CC, when used, use it along with metformin rather than CC alone. CC cycles require ultrasound monitoring. Gonadotropins alone may be considered rather than CC in therapy-naive women to improve ovulation, clinical pregnancy rate, and live birth rate. Gonadotropins can be considered in CC-resistant women as second-line agents. Either gonadotropins or laparoscopic ovarian surgery could be considered in women with CC or letrozole resistance. Following counseling on higher live birth rates and higher multiple pregnancy for gonadotropins. A low-dose gonadotropin protocol should be used to optimize monofollicular growth and to minimize multiple pregnancy. And consider cancellation in ovulation induction cycle if there are more than 2 follicles, more than 14 millimeter. Thank you.
Thank you, Dr. Rashmi. That was a great session. Shall we open the session for questions, or Reggie, sir?
The session, if you have any queries in the chat box, I think there are no queries actually. Anyone, I think
Sir, can
we
we
can
ask?
take, yeah, please.
Madam did not specify about the gonadotropins. Which gonadotropins that madam is going to use? Sir, we generally don't use LH. We only use FSH when there is a PCOS. And is there is any specific this one, sir, regimen which is going to be effective in particular group of patients? Is my voice clear, sir?
Yes.
Yes.
Ovulation induction patients, either HMG, the studies say that either HMG or FSH can be used. So it depends on the cost factor. So if the patient can afford, we can give FSH because it's obviously better, it's a recombinance. But we usually don't try to increase the cost in an IUI cycle or an ovulation induction cycle. So what I personally use is HMG for in an ovulation induction cycle.
Okay,
Even
thank you.
PCOS.
Thank you, madam. And in your slide, madam, you said agonist and antagonists are not used
Not
for
recommended. In ovulation induction or in IUI, we should not use agonists or antagonists. These again increase the cost, sir. We are not talking about ART here. IVF I have not included in this discussion.
Okay, madam, in the
Initial
when there is,
induction of IUI, not agonists. We should not use both.
madam, when we say that clomiphene citrate or letrozole can be given only for 6 cycles, so in case if there is a LH premature LH surge, so patient cannot be given, patient can be maximally given a clomiphene citrate or any ovulation induction drugs for a period of 6 months. So instead of cancelling it, when the dominant follicle reaches 14 millimeter, why should we not give an antagonistic like a cetrorelix or a ganirelix 0.25 milligram, madam? Is there is anything like that?
So again, we're increasing the cost of the cycle. So
Cycle,
premature
okay.
patient is ovulating, just
Okay.
we can cancel the cycle, just see for the next cycle also. If the pattern is repeating,
Okay.
most probably this pattern won't repeat in a normal dose.
Okay. Okay. Okay, madam. Thank you. Thank you very much.
Yeah, one point I would like to add is whenever you are using gonadotropins, if it is FSH or HMG, please monitor the cycle.
Yes.
So ultrasound follicular monitoring is very important when you are using gonadotropins. If it's letrozole and all, 1 or 2 cycles without monitoring also it will go. But with gonadotropins, definitely there is a risk of OHSs, and you have to have a strict cancellation policy. And if 2 follicles more than 17 millimeters is there, you have to counsel the couple regarding the risk of multiple pregnancy as well as OHSs. So you have to be very careful with gonadotropins. Fesi, any? Hello.
Hello.
Yeah, please comment.
And I didn't hear that. Sorry.
No, anything
Hello?
to any queries to Dr. Reshmi?
No. I think Rishmi has covered everything.
Yeah.
I think basically when we deal with ovulation, we have to systematically evaluate and don't, as Rishmi told, don't jump into IVF always, and it must not be the answer. So I think that systematically we have to evaluate the protocol showed, no, that has to be really followed. Don't think that patient may run away from you. And also we must tell that each has got its own limitation in the success rate. So that is what you have to, proper counseling is needed. That is the ideal method of treatment.
Okay. And there are no more questions in the chat box. And Konjumidin, sir?
Yeah. Reggie,
Hello.
once again. Audible?
Yeah. Yes, sir.
Yes.
Audible?
Yes, sir.
Yeah. Actually, here what we have to mainly in the when we are counseling the patients, or when we think about the biochemistry of the PCO, actually this hyperinsulinemia is the one which is resulting in hyperandrogenemia. So it is actually creating a cascade. So the importance of weight reduction and the drugs to reduce the insulin resistance, that has to be emphasized 2 or 3 times. The Dr. Manjunath has asked about the premature LH surge. Ultimately, these are the factors which are causing premature LH surge in PCO. So if we have not taken care of those things and just going ahead with the ovulation induction, ultimately it will induce only a follicle, but it will not result in a pregnancy. So that is one thing which has to be important. And I really appreciate Dr. Rashmi, who has pointed about the OGTT part, because that is the single most important investigation in PCO apart from the ultrasound. Thank you.
Any difference in thin PCOS and these PCOS regarding ovulation? Rashmi, can you throw some light on thin PCOS?
We have often found that thin PCOS patients are difficult to respond than the obese PCOS patient. Usually with a lifestyle modification and insulin resistance, after correcting the insulin resistance, usually obese PCOS patients are easier to treat than the thin PCOS patient. But for both, letrozole can be used. And these patients, thin PCOS patients, are more susceptible to OHSs also. So they require more stringent monitoring also.
Any addition?
In thin PCOS, see, we need to advise them to do exercise. Thin means doesn't mean that they have to sit quiet. And even though there is no need of weight reduction, they have to do the regular exercise, which will do a lot of good thing for thin PCOS.
Okay. So, Ajit?
Yes, sir.
Is there anything in the chat box?
No, sir.
Does letrozole cause endometrial thinning? This was asked by someone. Dr. Rashmi, there's one question.
Cannot,
Ma'am, can you hear me?
yes, I can hear you. What was in the chat box?
Yeah, does letrozole cause endometrial thinning?
No, letrozole usually doesn't cause endometrial thinning.
Is there any role for giving estrogen for improving the endometrial thickness?
And here actually the question regarding the letrozole causing endometrial thinning, the mechanism of action letrozole and clomiphene is totally different. Just because of the anti-estrogenic action and low estrogen and the feedback pathway getting activated, that is actually happening in the clomiphene. Just because of that anti-estrogenic effect, it acts on the endometrium and the cervix. Letrozole do not. Yeah, Rashmi, the next question, please take up.
Cannot see the chat box, sir.
Ma'am, Dr. Vijayalakshmi has asked, is there any role for giving estrogen for improving the endometrial thickness?
Same thing,
Usually, for ovulation induction, usually estrogen is not required. If a follicle is good and the egg is good, due to the estrogen produced from the follicle itself, the endometrium will grow. But in some certain cases, when we give clomiphene citrate, some cases we usually see a very thin endometrium. In those patients, we can consider, but usually with letrozole, we don't have to give estrogen.
Okay. I hope Dr. Vijayalakshmi's question is answered. And there's one more question in the chat box says, what is the maximum dose of letrozole that can be used?
So there are different protocols. The usual dose is 2.5 mg twice daily for 5 days. But in some patients who are letrozole resistant, so in those patients, I have used 2.5 mg twice daily as an extended protocol for 7 or 10 days. So that's the maximum.
I hope all the questions are answered. And there's nothing more in the chat box, sir.
And I just would like to emphasize on the point of using estrogen. Estrogen is being used left and right in the conventional means irregular ovulation induction cycles immediately after seeing the thin endometrium. Only advantage which you can get after giving the estrogen, oral estrogen in ovulation induction cycles, you may get a better endometrium. Nothing happens beyond that. It will not help for any increased implantation or anything. And it is actually hamper the further progress. It may the follicles can get regressed earlier. So actually, it does harm than good.
Yes,
There's
sir.
one more question, sir. When to consider HMG following a CC cycle?
So in a sequential therapy, what is advised is CC for 5 days, followed by HMG for 3 days.
I hope Dr. Rashmi has answered all the questions. So, Raji sir?
Yeah, I would like to congratulate Rashmi for that elaborate and a detailed discussion on ovulation induction in PCOS other than ART. So I think it has made our panelists, and for me also it is easy to conduct the panel because there will be some overlap in some questions and answers and all those things. So I think Rashmi has made the job easy for me, and that was wonderful coverage, and almost all the queries also answered. Thank you, Rashmi, for giving us a very nice talk, and in a very short time also she prepared and she said yes. Thank you. Thank you, Rashmi. Thank you very much. So Ajit?
Yes, sir. So moving on to the next session. Now we have a panel discussion, which is managing infertility in PCOS, practical points. For this, our very own Reggie sir is the moderator. Reggie sir is the Associate Professor of Department of Reproductive Medicine and Surgery, Government Medical College, Trivandrum, Kerala. He is the Chairperson, Reproductive Medicine Committee, Kfog. He is a member board of Surgical Super Specialties, KUHS, Joint Secretary, IFS Kerala Chapter. He's been the former chairperson of the Academic Committee of Kfog and former editor of the Kfog Journal. Over to you, sir.
Thank you. Thank you, Ajit, for the kind words. I think we will move on to the panel discussion. So we have 5 eminent panelists from different societies. We have Cochin Society, that is Dr. Fessy Lois. Fessy, who is docent need any introduction. Welcome, Fesi. Fesi is Professor and HOD, Department of Reproductive Medicine, Amrita Hospital, Amrita Institute of Medical Sciences, which runs an MCH program in reproductive medicine. He's also the past secretary of Kfog, now the secretary of Kerala chapter of IAGE, and now he's secretary of Kfog's Cochin also. Welcome, Fesi, sir. Then we have Dr. Ambuli Juice, who is a consultant reproductive medicine in I think Kraft. She was in Kraft Hospital. She was in Rajagiri Hospital, and now working as a consultant reproductive medicine specialist in Little Flower Hospital, Angamali. So she did her a fellowship course in reproductive medicine and from Dr. Urmila's training center. Then fellowship from Kraft Hospital. Welcome, Dr. Ambuli Juice. Thank you for joining.
Thank you so much, sir. Thank you for having me here.
And we have Dr. Sunita Muralidharan from Palakkad Society. So she is a consultant fertility specialist, BFI ARMC Palakkadu, and she's practicing obstetrics and gynecology for the past 27 years. Welcome, Sunita Muralidharan, madam.
Thank you, sir.
And we have Dr. Deepak A.V. Deepak A.V. is a professor, Government Medical College, Thrissur. He is running the infertility clinic in Thrissur Medical College. He was old alumni of Trivandrum Medical College, and he is very much interested in running an infertility clinic. And sooner, I think the IVF unit in Thrissur also will start functioning. So his other interests are in high-risk pregnancy, operative gynecology, and vaginal surgery. Welcome, Deepak. Deepak is from Thrissur Society.
Thank you, sir. Thank you, sir.
And we have Manjunath, Dr. Manjunath. He's associate professor in Al-Azhar Medical College, Todupuzha. He represents Malanadu Society. Manjunath sir has got a lot of variety hobbies, and he's a teacher. Welcome, Manjunath sir, to this panel.
Thank you very much, sir. Thank you very much.
So I think all have my slides are visual. Is there any problem in visualizing the slides?
No, sir. No problem.
Yeah. So shall we start the session?
Make it slideshow.
Sure, sir.
Slideshow.
I think it is slideshow. Now it's slideshow.
Now it's slideshow.
Okay, thank you, Pussy. So we'll move on to without much wasting much of the time. We will just move on to the session. So I would like to pay my gratitude or thanks to Dr. Kunjumuddin and Subhash for providing this platform. I'd like to thank Kfog, and I hope that this will follow. This will be continuing in the next 2 years also. So I will come into the first case, that is the couple. We always go for a couple-based approach in infertility, and we have a couple, Mrs. PCO 24 years and PCOD 27 years. It's an IT couple living in a metropolitan city and happily married for 3 years. Only trying was only for 2 years. There is inability to conceive. Male examination, semen analysis, all normal. Relevant points again in histories. She has got irregular cycles, that is around 3 to 4 months in 3 to 4 months. Then she has got an FG score of 12. Acne is there. BMI is on the higher side. Waist hip ratio of 1. So other investigations is like that, as Rashmi has mentioned. OGTT is 160 on the higher side. Has got an abnormal lipid profile. Again, FNP or follicle number per ovary is around 32 on one side and 25 on the other side. Volume is also on the other higher side. That for diagnosis, you know that the volume of ovary required is 10 cc. So one side it is 21 and the other side is 15 cc, and her AMH level is 4.8. So PCOS, as all of you know, that if we still go for the Rotterdam criteria, all the 3 criteria are there, and all 4 phenotypes are well explained by Dr. Rashmi in the previous discussion. So what are the treatment options in anovulatory infertility? So before conceiving or they're coming to you, so what all preconception or lifestyle modifications you should go for? I think I will start with Ambali.
Yes, sir. So first of all, like I mentioned, complete assessment, a general assessment, including a detailed history and physical examination, which has been taken in this case. Then we'll review if she's on any teratogenic medication. For example, if she has hirsutism, say if she's on spironolactone or certain anti-diabetic medications which are not safe in pregnancy. Then do a complete metabolic workup, including the OGTT, fasting glucose, your lipid profile, and maybe liver function tests if needed be. Then see that her micronutrient status is assessed. For example, PCOS is often associated with obesity. So these patients are at a higher risk of folate deficiency, vitamin D deficiency, and they also require a higher dose compared to the general population during pregnancy. Then if she's been on metformin for quite some time, her vitamin B12 stores might be depleted. So all these factors need to be addressed. Then comes the most important part, lifestyle interventions. So in lifestyle modification, detailed dietary counseling.
So I think we will be coming on to it. So before going for this thing, is tubal evaluation mandatory?
No, so tubal evaluation, according to ESHRE, it should be an individualized approach, one based on the personal characteristics and the population, this thing of tubal infertility. So suppose a patient has got, say, a history of any abdominal, suppose septic surgeries like peritonitis, or if she's had a pelvic surgery, or she has concomitant endometriosis, or suppose she has a history of pelvic inflammatory disease, then I would go for a tubal testing at the outset. But otherwise, if it's just a case of
Then you
PCOS,
have to go for a laparoscopy rather than
yes,
HSG or
a
anything.
laparoscopy, yes, yes.
Okay. So the most important thing is you have to optimize and you have to control your blood pressure. You always check the blood pressure, always check the OGTT, always check the lipid profile. So if there is any other things like nutritional deficiency, also you have to keep in mind because most of them are vitamin D deficient, and you have to add on vitamin D in their diet. So how to optimize weight again? Ambali?
Yes, sir. So to optimize weight, one is sustainable changes have to be advised to the patient. One is your diet. So a sustainable, healthy diet. There is no consensus that any particular diet is superior to the other. So a calorie deficit of at least 500 kilocalorie is advised. Now, this is in case of obese PCOS. If it's a lean PCOS, still dietary modification is important, keeping in mind the metabolic constraint of the patient. As in a healthier dietary approach has to be this thing. Then in an obese patient, we counsel them that at least a 5 to 10% weight reduction will give like significant results to them. And also exercise. Exercise based on what is our goal, if it is to maintain your existing weight or and to prevent excessive weight gain or to decrease weight, there is specified, we counsel them in detail about the timing and duration of the exercise.
Okay, basically, as President Kunjumuddin sir told that you have to reduce the hyperinsulinemia, to increase the insulin sensitivity, and even a very minute 5% body loss, weight loss, can restore her ovulatory cycle. That's what the studies show. So again, the lifestyle modifications, you can't just tell them that you reduce weight 5 kilos in one week or 2 weeks or 1 month or something like that. So always all the goals should be very specific, measurable, achievable, realistic, and timely. And you have to evaluate and reevaluate in time. So any other panelists want to opine?
No, regarding the tubal patency, I like to add that suppose if the patient had regular cycles with the polycystic ovaries or patient had taken ovulation induction before and patient had ovulated or with the ovulation induction cycle, so his regular male factor was there. Then before ovulation, trying for a next ovulation induction, we have to see the tubal patency. Otherwise, at least one cycle we have to give 1 or 2 cycle ovulation induction before we going for a tubal patency. I just allowing to add that point what Reggie you
So
had
how many
asked.
cycles you will give for ovulation induction in a PCOS? The basic pathology is an ovulation. So before tubal patency testing, if every other things are normal, semen analysis is normal, there is no uterine pathology, and how many cycles you will give ovulation inductions?
At least one cycle we have to properly do the ovulation induction and do the proper monitoring of the ovulation cycle is needed. Just by giving ovulation induction is not needed, not enough for a PCOS patient. At least one cycle and we have to properly see the follicular tracking at least one cycle. And then if the factor is also semen factor is also normal, then we will go for a tubal patency before the second cycle attempt for the second cycle, because each cycle, suppose that the patient is needed gonadotropins. We'll come to that later, but then it will be before going for that, we have to do that's what Dr. Ambli was telling. You have to individualize the case. Suppose if there is a that is most important in deciding that how when we do the tubal evaluation.
Okay. Since the basic pathology is an ovulation, I think there is no harm in giving 3 to 6 cycles of ovulation induction, because basic pathology is an ovulation.
But but that's what, no. Suppose if the tubal factor we have ignored at least, and patient is responding to ovulation induction at least 1 or 2 cycles, then we have to do the tubal evaluation.
Very young patient, but again, you have to check for other factors also. So, yeah, we'll go to the next question. So, what dietary interventions you have to do? Any particular diet? I think Manjunath, Dr. Manjunath, are you there? Can you unmute yourself and?
Yes, sir, I'm there.
Yeah.
Sir, any dietary modification as such, we have to always calculate according to her body mass index. So according to that,
So one size doesn't fit all.
Sorry, sir. One size does not actually fit all, because the dietary modifications all depend on the body mass index. And depending on the body mass index, I would like to tailor the kilocalories per kg body weight for a patient for a per day. And we will ask her to take less carbohydrate. As we do it for any of the gestational diabetes case, we tell them to restrict for a 50 or 55%, then cut down the reduce your fat intake by another 20, only to 25% of the total calories which is required per day. Another 20% should be by the protein. So this will give her a balanced diet. As such, this is the one thing that we tell the patient to take, and we tell her to take a lot of vegetables and to drink plenty of water and active exercise. I think with this, her dietary criteria should be met. I think her dietary requirement should be okay with this kind of an approach, I believe, sir.
So what about newer diets like keto diets, Mediterranean diets, all those things are there, no? Any specific diets?
Sir, I didn't get you, sir.
Diets like newer diets are there, no? Keto diet is there, protein only diet is there, Mediterranean diet is there, DASH diet is there. So many diets are coming.
Okay, sir. Sir, in med diet, we always ask the patient to lose weight.
No, is there any difference in PCO patients? Do you advise?
Sir, med diet. Okay, sir, I'm not very much sure about it, sir. I'm sorry.
Yeah, usually studies have proven that there is no, you cannot recommend a specific diet to this patient. As rightly told by Dr. Manjunath, you have to tailor according to the patient's need. Your BMI has to be taken, how hard work, or whether she's having a sedentary work or a hard worker. All those things have to be kept in mind before telling the calorie deficit or the exercise. So what about exercise?
Sir, exercise is very much important. We ask a patient to do an exercise. It depends on what kind of an exercise they do, sir. So for the prevention of weight gain and for the maintenance of the health, we advise them to take 150 to 300 minutes of moderate intense activity, or 75 to 150 minutes of.
Your voice is breaking. Hello, Dr. Manjuna, voice is breaking.
It's got disconnected, I think, sir.
Okay, can anybody else? Dr. Deepak?
Muscle strengthening activity.
So
mainly we tell them to have an exercise which is a muscle strengthening exercise, especially the aerobic exercise which they have to do, and it should be done at least for a period of 5 weeks a week. And
so you have to stress on exercise. Okay, so different our 2023 guidelines have specified that you have to do that. Is if suppose if it is a moderate intensity, you have to, that comes hardly around 40 to 45 minutes per day, and that too only for 5 days you have to do. And what you have to specify or you have to stress is the muscle strengthening activity. Okay, so What about any personal fitness mantras for all these PCO ladies? I think Dr. Sunita, madam.
So there are a lot of mantras and has come into vogue, and I would suggest there should be a group so that am I audible?
Yes, yes, madam.
Yes.
Sunita, madam, your tips, practical tips to reduce the weight fitness.
Yes. So the whole family should be behind her so that she will be encouraged to do the follow the fitness schedule. And if she is in a group or with friends, then they will be helping her to lose weight. Along with this, there are we can advise her like some physical activity is better than none, and the amount of sedentary sitting or reducing the screen time and all those mantras which we are seeing on the screen. So many tips are there. And the most important thing is she should be encouraged, or the patient or the couple should be encouraged to uh, take charge of their health, and also see that the fitness is for a longer duration, not for just getting pregnancy, because a sharp weight gain doesn't help them. Only a long duration sustained weight gain and healthy goal will help her to achieve a pregnancy and carry it forward in a proper way. So that should be our advice.
So basically, almost everybody is carrying a smartphone or a smartwatch. So we can ask them to count their steps. We can ask them to count the calories they eat. Okay, all those things we can, I think you can tell the patients. Any other advice, Fesi sir?
No, what I usually tell is that, okay, you must do at least 45 minutes to 1 hour of some walking. Walking is better if you are not going to gym. And for that, if you don't have time, I usually tell, if you are a working woman, you have to while going or coming from the job, you just get down in one stop before and start walking. That is what practically I tell. And otherwise, the goal must be at least walk briskly for 1 hour. Or if you are not working, you can start some habit of going to temple or church regularly, so that you will walk properly at least for 45 minutes. Or next thing is that stop in between, as Dr. Manjuna told, we can restrict your carbohydrate diet and have in between meals, what eating has to be reduced. So in addition to that, that also, because suppose if you skip one big meal and start having intermittent eating, then it won't be useful. These are the two things which I tell. I think we can hear from other panel members what they find which is more practically useful, so that we can also take
Dr. Ambli,
tips
Dr.
from them.
Deepak ഒന്നും പറഞ്ഞില്ല. Deepak.
I fully agree with Professor sir. Professor, am I audible?
Yeah.
Yes, yes.
Hello. Okay.
Yes, you
Okay. You have to look for what diet they are following, and you have to modify depending upon their diet.
Deepak's
And
strategies.
regarding the
Deepak's
yeah,
strategies.
we have to ask them what they are following, what diet pattern they are following, and little bit modification. Start with small modification in that diet, and achieving the goal.
Okay. Dr. Ambli?
Sir, I tell them, like, I give them a target. Okay, 45 minutes, 50 minutes is a target, but it is mostly not achievable. So I tell them anything, start where you are. Start with 10 minutes initially. Keep a diary, keep a track of what you've been doing. So and self-motivation, and especially if the husband also, mostly, I mean, the male factor is usually ignored. Even if seminars is okay, if they start working out as a couple, like if whatever exercise they enjoy doing, like running may not be for everyone. So dancing, exercise, whatever, but keep a track of your progress so that you get a visual idea of how you're doing and where you are.
So basically, I think you have to involve the partner. That is very important. And you have to keep a diary. And even if she is not attaining that weight loss, you have to congratulate her. Even a 500-gram weight loss, you have to congratulate her. And you have to tell that this is good and this is the persistence is very important. But again, studies, there is no supporting one type of or intensity of this thing. Any type of exercise is fine rather than sitting lazy. പണ്ട് കാരണവന്മാരൊക്കെ പറയുമായിരുന്നല്ലേ, നമുക്ക് പ്രഗ്നൻസി ആയില്ലെങ്കിൽ പോയി 100 പ്രദക്ഷിണം വെക്കുക അമ്പലത്തിന് ചുറ്റും, അല്ലെങ്കിൽ അമ്പലത്തിൽ ഫിസി കറക്റ്റ് ആയിട്ട് പറഞ്ഞു. So that is a method of exercise. So coming to the next thing, what is we have already heard Dr. Rashmi talking on the first line medical management. So we will go for the first line medical management, that is the for ovulation induction, that is the letrozole. So letrozole, as all of you know, that it is an aromatase inhibitor, and there are different types of protocols, and we will be going into the different protocols. Deepak, can you start with different types of protocols, what you give, what is the dose of letrozole, and what difficulties you are finding with letrozole, and what are the different regimes?
Usually you start with 2.5 BD for 5 days, starting from day 2 or 3, and look for the follicular look for follicular tracking. And suppose she's not responding, you may have to reevaluate the case. Is there any other missing? You look for hypothyroidism, hyperprolactinemia, and other causes of anovulation.
So basically,
anovulation.
your
And
your
you may
start dose
add on
is
the extended
2.5 alla, your start dose
2.5
is
mg.
5 milligram or 2.5.
5
What is
5
your
milligram.
start?
5
5 milligram is your
milligram.
start
5
dose.
milligram.
Okay. So if she ovulates, fine. How many cycles you will continue?
Okay. If she ovulate, they say 3 to 4 cycle, we can continue with the same dosage.
So what advantage of letrozole you find
And
usually?
you may ovulation, the advantages over the clomiphene citrate, the endometrium will be not thinned out as in case of clomiphene, and the ovulation rate is more than the clomiphene. A live birth rate also, and it usually go for a monofollicular development. So
Very good.
chance
That
for
is
multiple pregnancy and OHSS, that complications are less.
okay. So basically, letrozole is associated with mono-ovulation. This is associated with a very good endometrium, and usually there is a reduction in the multiple pregnancy rate. So suppose that is why the letrozole is the first line pharmacological management in ovulation induction in infertile anovulatory women with PCOS. That is again the 2023 recommendation. So again, the problem is sometimes in some countries letrozole is still off label. So that is the problem. So suppose you are giving the usual dose of letrozole and not responding. So you're take on, that is almost 15% of women who are taking letrozole is not responding. So what all you will think of, Dr. Ambuli?
Yes, sir. So one, as Dr. Deepak rightly said, confirm the diagnosis of PCOS, because irregular cycles and an ultrasound diagnosis is usually the reason why we label as PCOS and start off. So it could, I mean, just rule out a coexistent thyroid disorders or prolactin disorders also, which should be done. And sometimes make sure she's not, take a detailed history to rule out other rarer causes like hypogonadotropic hypogonadism, or even very rarely gonadotropin resistant syndromes. Then hirsutism, if that was a cause for a diagnosis, CH should also be considered. Then look at the weight of the patient and see our dosing and what regimen we've used. I find 2.5 mg, many patients do not respond. So a starting dose of 5 mg would be better. And if she's not responded to that, maybe we'll consider a extended regimen the next cycle.
Okay, this is a study published in 2023. So here also there is the cumulative ovulation rates were significantly lower in patients with who had late menarches, had a higher LH-FSH ratio, had a higher AMH, that is more than 9.78, and a free androgen index of more than 5.99. So suppose if there is letrozole resistance, what are the different options? Basically, can you show some?
So letrozole resistance as such, if you tell, it has come recently on. Previously, when we were looking to the literature, we were seeing the definition as clomiphene resistant. That is, if a patient does not, respond with the maximal dose of clomiphene, that was given as a clomiphene resistance. But nowadays there are articles which came last year as letrozole resistance also. Similarly, we are not responding with a 5 milligram. That's what there is no clear-cut definition about letrozole resistance. But in those cases, patients not responding with letrozole. But I want to add that when you see about response, you have to look into the proper ovulation tracking. That is important. Mm. Hello, can you hear me?
Yeah, yeah.
Yeah.
Okay.
Yes,
When
yes.
the patient is not responding to the means, we have to properly see the ovulation induction, follicular tracking, and see the response. And if the patient is not responding to the usual 5 milligram, then we have to either go for a extended letrozole. Extended letrozole, when started initially, the regime was 2.5 milligram 10 days, starting from the first or second day of the periods. Now there are studies with extended letrozole even with 5 milligram for 10 days. And then we had to add for the, say, is still not responding, we have to add for a sequential regime. That means we have to add gonadotropins. So instead of going for, I like to always go for instead of gonadotropic alone regimes like step-up protocol or chronic low dose step-up protocol, like to always go for a sequential, that is known as sequential regime. When you followed clomiphene or letrozole with a gonadotropin sequential regime. So in PCOS patient, letrozole, if not responding with 5 milligram, as Dr. Ambli told, most of the PCOS patient may need 5 milligram. And then followed by giving it extended letrozole, not responding, we add the gonadotropins.
Any difference of opinion from other panelists?
We go for the same as Dr. Fessy told.
Okay. So basically, you have some other regimes like extended letrozole regime. Step-up regime is there. You start with 2.5, 7.5 to the maximum. You can add on with clomiphene. Some papers have seen that you can add on. Some people are following also. But again, randomized control studies are absent. So clomiphene plus letrozole is another option. Stair-step, you can have a stair-step regime, which is a very good regime. You will get 80 to 90% ovulation with stair-step. That is, you don't have to wait for the bleeding. So you give, so that is stair step is, yeah. So this is sequential. This is stair step protocol where you give 2.5 milligram for 5 days or 5 milligram for 5 days, and you don't wait for spontaneous or progesterone induced withdrawal bleeding. So increase the dose from 10th day onwards. So 10th or 14th. Suppose if your endometrium is thin and no follicle is growing, you increase the dose to 7.5. Suppose if you start with 5, you increase to 7.5. Suppose if you start with 2.5, you increase to 5 milligram. So with that, the ovulation rate has been increased to 80 to 90% in retrosome-induced cycles. So we have so many other protocols. So basically, this study that is again published in 2023 or 2023, again, the 2.5 dose, usually we won't go for the 2.4, that it can lead on to an inferior response. So you can consider extended regime, you can consider stair-step regime. All these things can be considered to shorten the time of ovulation and pregnancy. So anyone using anastrozole, suppose if it is resistant and all. Any one of the panelists? Anastrozole.
No.
Some few companies are having anastrozole tablets. Dr. Fessy will be
I
having
don't,
some
I
experience
don't,
with
I'm
anastrozole.
not using, no, we are not using anastrozole. Even the
Okay.
literature studying it is not superior, but it can be given. That's all.
Yeah, but it is not usually used. But again, suppose if there is a resistant case or if you want an alternative, definitely there is an option for anastrozole 1 milligram from day 3 to day 7. But it can be used as an alternative to clomiphene or letrozole. Just keep in mind because it is another oral ovulation. So coming to the next thing, that is the time-old, well tested clomiphene, from green blatt, that is clomiphene citrate. So what are the regimes usually you go for clomiphene citrate? Manjunath sir.
Thank you for this question, sir. Sir, we generally don't start with 50 milligram because most of the time, even if there is a follicular development, the ovulation will not happen. Only 44% of the patients who have taken a 50 milligram will ovulate. Whereas if we start with 100 milligrams, as much as about 64% of the people are going to ovulate. So the ovulation chances, if we have to increase, but there is always a disadvantages of multiple follicle developing, and there is a thinning of the endometrium, and the mucus will be very much thin, anti-mucus activity. But I would like to start with 100 milligram of clomiphene citrate from day 2 or day 3 or day 4 for 5 days. I'll give. Then I'll go for the follicular monitoring on the day 9 or day 10, because the dominant follicle would have selected by that time. So depending on that, we will advise them to have a generally we don't give a trigger when we use the clomiphene citrate, because the HCG normal LS secretion is going to happen. But in case if there is an ovulation, yes, we give a trigger, then followed by a timed intercourse, sir. I would like to start with 100 milligram. Maximum I will give 250 milligram, beyond which it is not going to help. So maximum 3 cycles, sir, of clomiphene citrate starting with 100 milligram per day would suffice for a patient.
Any other opinion from the panelists?
Yes, I like to differ with that because I usually also start with 100 milligram, but because of the anti-estrogen, as Manjuna told, can occur with high dose, I usually don't go above 100 milligram. And if needed, then we add sequential regime with the gonadotropins if there is no hyperstimulation. And of course, I always give HCG trigger if there is no I mean, more than, if not more than 3 follicles are not there, I'll give HCG trigger in clomiphene also.
So basically 80% of women will ovulate, but again, the conception rate is very low as 30 to 40% because of the anti-estrogenic effect, as rightly told, on the endometrium as well as on the cervical mucus. Again, the twins and the triplet rate, they are very high with clomiphene citrate, that is around 5 to 7%. Again, a very, very small chance of OHSS rate is also there. And as rightly Dr. Rashmi has pointed out, there is a very, very rare chance of borderline. There is an increase in the borderline ovarian tumors if you are giving more than 12 cycles of clomiphene citrate. So there is something called clomiphene citrate and resistance and failure. We have already mentioned by Dr. Reshmi. So what are the strategies for what other strategies you will think of whenever there is a clomiphene failure or clomiphene resistance? Dr. Sunita madam?
Yeah. So when we are using
You have
clomiphene,
come across these cases like clomiphene is not responding.
Yeah. But of course, we are using more of letrozole nowadays. If clomiphene
Letrozole?
resistance is there, it is again due to the dosage may not be correct, but I am not for increasing the dosage. It might be, she might be having a high BMI or a high LH or a insulin resistance. Also, the anti-estrogenic effect is playing a role. So, I try to change it to a letrozole cycle or add gonadotropin. And for the endometrium per se, I would like to add arginine, ecosporin, which will increase the blood circulation. These are some of the strategies I use to improve the, if I have to repeat the clomiphene, I add these things plus gonadotropin. So,
Deepak, any difference of opinion? We have the option or we have the blessing of letrozole. So now letrozole has almost replaced clomiphene. But whenever, sometimes so many people will be using clomiphene. Any other, definitely you can go for alternative regimes. What is your idea? That I think we will be coming. Any other panelists, any opinion regarding management options of clomiphene resistance or failure?
Sir, we can also add a dexamethasone from the day 1 to day 10. Dexamethasone, in case if there
What
is
your dosage, sir?
Sir, dexamethasone, we use it in a dose of 0.5 milligrams per day from day 1 to day 10, because if there is increase in the dihydroepiandrosterone, if there is a more androgen from the adrenal glands.
Again, voice is breaking. Any other panelists want to opine regarding adding dexamethasone to letrozole or clomiphene? Yes, sir.
No, I think I also, if the patient is one cycle is not responding, or if,
really going to help the
okay,
response.
carry on, Manjunath. Carry on, Manjunath.
Sir, adding a dexamethasone in a dose of 0.5 milligrams milligram and giving a metformin in a proper dose and asking a patient to exercise and diet control. With that, I think ovarian response should be good with a clomiphene citrate or to any of the ovulation induction agents. And of course, we always have a human menopausal gonadotrophin, the FSH in hand, in case if we need, we can add up in between the, in case if the follicular response is not favorable. It's not
So I think clomiphene,
up to what we have expected.
I think it's clear. Any additional points? Anybody wants any panelists want to add on any points to clomiphene citrate?
I think we are dealing with two things. One, it is clomiphene, resistance. Previously, when we were not able to license to use clomiphene, letrozole, or when the letrozole use was not so prevalent, then we used to alternate cycle. We used to give letrozole and clomiphene. But if the endometrium is thin, that is other point which we discussed, that option, then we have to. It is not basically is different from the clomiphene resistance. It is one of the reason for clomiphene failure. In those patients, we have to either wait for 2 days. If the follicle is more than 17 millimeter and still endometrium is thin, and if it is persistently it is thin, we have to rule out any endometrial problem by doing hysteroscopy. Otherwise, we have to just see 2 days. And there were some studies, but not widely accepted, is about the using the sildenafil to increase the vascularity. And as Madam told, we can try enlarging, but
all those things. But
I
again,
don't have much experience with that. But we can try that. But I am against using the estrogen. Some people give estrogen at this stage to
improve the
if it
endometrium.
is endometrium. But I believe that if you give estrogen, it will affect the LH surge and proper luteinized, follicle release. It will be affecting. So if the follicles has ruptured and without giving external HCG and the endometrium is thin, as a support, I usually give along that progesterone if ovulation induction is done, estrogen I usually give.
Thank you, Tracy. So, any experience on tamoxifen? Anyone?
Yes, sir. I've
It's
used
another yeah.
Yes, sir. In a dose of, it can be used along with, like in the case of CC resistance, sometimes used with CC plus tamoxifen can be given. It takes care of the endometrium. Results are actually, as in with tamoxifen, the thinning with clomiphene is kind of taken care of. And also, as a single, this thing also, it can be used instead of letrozole, a similar this thing. So it can be given in a dose of like 20 mg, 10 mg BD or 20 mg BD from day 2 for the next 5 days, and then monitoring as per your usual ovulation induction.
Just like anastrozole, again, tamoxifen can be used as a second line or third line. You just think, suppose if there is resistance and all, but difficult to get. But again, some pharmas are providing tamoxifen and anastrozole. So what about what is the comment on insulin lowering medication? Somebody can take these questions.
Yes,
So regarding the pathophysiology of the PCOS, it's mainly the hyperinsulinism that and abnormal LH both causes. And there's follicular atresia, anovulation. All these are due to the insulin resistance that happens. So insulin, the metformin, that is insulin sensitizing agents, will be having a role in normalizing the hyperinsulinemia and hyperandrogenic milieu, and the ovulation may be regained. They will be ovulating.
So what is
So
your dose of
usually
starting metformin?
Start with the lowest dosage, 500 OD, and then step up with
any particular
500
advice
BD.
you will give when you are giving metformin?
Eat with the diet, with the food you can eat, and in a prolonged use, there will be vitamin deficiency that can be supplemented.
Okay. So what about newer anti-diabetic medicines like GLP-1? Any experience with GLP-1 and all the new glutides and all? Ambuli, madam?
Sir, in patients planning pregnancy, these are not advisable. GLP-1, as Aishwarya recommends that it not be used. It's still experimental. Even the most commonly used myoinositol is considered experimental, and patients should be explained as what they say. Metformin can safely be given, especially not for all patients. Patients who are at a high metabolic risk, say high BMI, or who have a deranged OGTT when you've screened, or who have a personal history of diabetes. The newer ones, myoinositol, if the patient is, say, intolerant to metformin, because GI side effects are significant with it. And also as an adjuvant with metformin, there are some studies which show that metformin versus plus placebo versus metformin plus myoinositol, there are better weight reduction and insulin resistant changes with the combination.
So all these insulin sensitizers which are used in diabetes, like GLP-1 receptor antagonists and DPP-4 inhibitors like sitagliptin, then SGLT, that dapagliflozin, linagliptin, all these have been used, but again, the studies are coming up, and some especially with the semaglutide and all, the studies are promising regarding weight loss and regarding the insulin resistance. But again, we have to wait for more detailed studies rather than jumping into the newer drugs. I think the best and the time-tested one is metformin. So that is the one which is recommended, that has been recommended also, with very minimal side effects, and usually 500 to 2 grams. Up to 2 grams you can go. And prolonged use, you should always think of vitamin deficiency, especially B12. You have to supplement the B12 level. You have to monitor the B12 levels, and you have to supplement it, especially if it's a vegan or a pernicious anemia or anything like that is there in addition to your our polycystic ovarian disease. So any other opinion regarding insulin sensitizers, other panelists? Percy?
I always prefer metformin, even though gastric side effect is there, which can be minimized if slowly over first 1 week OD dose, then BD, and then TID. And the slow release, sustained release tablets is not found to be superior to that. But there are some people telling that it is better, but I have not found that better with sustained release tablet also. And only if those patients which have cannot tolerate metformin, I usually give myoinositol. But as Dr. Ambli told, there are some studies coming about with the combination of metformin and myoinositol, so that the metformin dose can be reduced or the side effects can be reduced. So I don't have wide experience with that. Sunita Madam can add, or anybody can add with that.
Is it a blanket treatment for all PCO patients? You will give metformin?
No.
No, not for all. But if there is ovulation problem, I usually like to add. That means if there is a regular cycles, I usually add. Not for all PCO patients, but if there is regular periods before ovulation induction or along with that ovulation induction we give, it is found to be very useful if you started metformin with ovulation induction. I usually give the ovulation induction, not continuous cycle, alternate cycle. By the time we give the second cycle after the gap of 2 months, patient would at least the hyperstimulation part is found to be less, even though studies is found it is less with the control over hyperstimulation for IVF. In practical for routine ovulation induction also, I found to be decreasing the incidence, not completely avoiding, slightly decreasing the incidence of hyperstimulation.
So many studies are coming with myoinositol, the
Madam,
ratio of 40:1 and all those. Yes.
Sir, first before we start, what the study says that always we have to demonstrate the abnormal glucose tolerance test. And those patients who have abnormal glucose tolerance test will get benefited. Of course, as Sir said, it can be added generally as a blanket treatment. But its study states that to be specific, we have to demonstrate abnormal glucose tolerance test. Especially we give it in obese. Of course, the obese, they need a metformin, but even in thin PCOs, in other PCOs, demonstrate it, and then we can start the patient on metformin. Or as Sir said, it can be given from the beginning itself. Both holds good, Sir. That's what
medical college experience.
we have to do GTT as Manjuna sir said, and in the medical college, the thing is that the most of the patients some of the patients are referred cases, and when they came to the medical college, they have tried
Already
all these
on.
ovulogents. So they may be
You have
on
to go for.
metformin for so many months. So we may have to switch it to sequential protocol for the ovulation induction.
So coming to the first line is over. So coming to the second line, that is regarding laparoscopic ovarian surgery. I hope all of you have done or seen or laparoscopic ovarian surgery. Before it was done left and right for all patients with PCOS if they are not responding to your oral ovulogents or gonotropics and all. You keep it, you post them for laparoscopic ovarian surgery, drilling, left and right drilling and all. But again, nowadays, it is coming into a very, very number. Any particular indications for laparoscopic ovarian peeling? I think Dr. Ambuli can start with.
Yes, so like you said, a very strict patient selection. Patients, say, of lean PCOS who have very high LH levels of more than 10, and also very high IMH levels with a large ovarian volume and a large stromal volume that is calculated. Patients who have a demonstrated history that they don't respond to gonadotropin stimulation, and especially patients who are not willing for IVF, who maybe want to try sequential regimens of ovulation induction. In those patients, it could be considered. But with the advent of IVF and the ease and the safety of it, maybe the role is to be very well screened before the
Okay.
patient selection.
So if given a chance, what will you do? Suppose if there is an ideal patient, what is the rule of 4 or what is you want to enlighten the audience regarding the laparoscopic ovarian peeling?
Sir, I didn't get your question, sir. Sorry.
Can you enlighten regarding laparoscopic ovarian drilling? If you are given a chance to drill a patient or do an polycystic ovarian drilling,
Yes,
so what all precautions? Yeah.
Yes, how to go about it is one, a general laparoscopic precautions like before entry safety procedures. And
Yeah,
once you go in, you visualize both the ovaries. You make sure you lift up the ovary away from the vital structures and then stabilize the ovary in your one hand. And with your dominant hand, you make, classically, it has been described as the rule of 4. That is 4 punctures of 4 seconds, 4 millimeter, 40 watts each, delivering 640 joules per ovary. But studies also show it should be a proper calculation. It should be smaller ovaries need lesser dose, larger ovaries need more dose. So an ovarian volume ideally should be calculated prior. And post procedure, you should make sure that the ovarian
you shouldn't take the decision on table.
On table, yes, sir.
Yeah, that
AMH
is very
documentation should be there beforehand. Patient should be counseled about the long-term effects. Like this can have, maybe it can correct your ovulation issues for the next 1 year. But there is a chance of a premature ovarian failure in the long run, even in a PCOS patient with irrational, or maybe if the drilling is not done rightly. Secondly, during the procedure, the surface is going to be hot. So you have to make sure that it doesn't touch immediately and you wash it off, cool it off with a saline, give a vigorous wash, and ensure hemostasis before closing, even though it is a minor procedure.
Tracy sir would have done so many PCO drillings in old times in Adapal and all.
Yes,
Sir,
yes,
your
sir.
opinion.
I think almost the concept is changed after this antagonist with agonist trigger came. But before that, when we have to do induce that letrozole also for some patients will hyperstimulate. Even the letrozole was not widely used. When you use clomiphene, definitely. Even when you are going for IVF stimulation with agonist, there is either we have to cancel the cycle when the patient is taking the course, or we have to give HCG. So the in to avoid hyperstimulation, and we had to do laparoscopic ovarian drilling. We even and done many cases of laparoscopic ovarian wedge resection also. Only thing we had to properly select the patient, whatever be the PCO laparoscopic procedure drilling we are doing, not just a scan of PCO. We must not do the PCO drilling. You have to clearly document if there is an ovulation with the usual clomiphene or letrozole plus 3 doses of gonadotropin, or if the if there is some ovarian volume is big, stroma is thick, typical PCO ovaries. In those cases, definitely Even now, there is a role for doing ovarian drilling. Uh, but with the advent of the antagonist protocol with agonist trigger and the free sol strategy, the hyperstimulation can be totally avoided. But if there is an indication to do a laparoscopy for the patient, like other associated fibroid
Tubal
or
factor.
associated tubal factor, then definitely if the patient is having a bulky ovary with PCO with thick stroma, definitely we can do the PCO drilling. And as Ambali told, the initial 1 year is the period where you can get a good response, and we can counsel the patient. She need, even if we need gonadotropins or ovulation induction, the chance of success will be better if you go with that. So I think still there is a role for ovarian drilling, but it has reduced drastically, definitely, as Reggie told.
Thank you very much. So coming to the next question, that is, they have all finished after this, our couple, hearing all the pros and cons of laparoscopic ovarian dressing, they are gone for a laparoscopic, non-surgical option of gonadotropins. So I think all of you are using gonadotropins. Different types of gonadotropins have been well explained by Dr. Reshmi. So we have the option of HMG and FSH, LH, all those things. So what do you prefer? I think we will hear from Dr. Manjunath first, then go to each panelist.
Hello, sir. I didn't get the question because there was unstable.
Okay,
Hello,
then
sir.
I think Deepak, can you take it? When you use gonadotropins, what type of gonadotropins you will use, and how will you use?
I usually in sequential regime I use HMG or FSH. These are the two things I used to use.
Okay.
We are not starting the IVF, so that regimes
No,
IVF protocol.
no, not for IVF. So other cases, are you using?
HMG, the sequential
So what
regime.
regime is it? The sequential or
FSH?
not from starting?
Sequential regime. Sequential. Letrozole plus 3 doses of HMG.
Okay. So what about other Dr. Nisha? Hello, Dr. Ambali. Sorry, Dr.
Yes.
Ambali.
Yes, sir. So I would prefer a sequential regimen. The gonadotropin only regimen would be too cumbersome, expensive, and prolonged for a PCO patient. Probably not indicated. I mean, probably with the other better methods, maybe I wouldn't prefer it. In the sequential, I would prefer HMG. So in an ovulation induction cycle, FSH versus HMG gives comparable results. There is no significant difference in your live birth rate, and it is cheaper to the patient. So HMG definitely, sir.
Sir, I think you will be able to comment on chronic low dose and or any personal experience with chronic low dose that gonadotropin.
Sorry, sir.
Chronic low dose regime for.
Sir, I have personally not used it, sir, because a sequential regimen gives good enough response, and even better than sequential. Sometimes I find the extended letrozole regimen itself gives a better response than sequential regimen with PCO patients. If not, yes.
Yeah, what happens is usually all this fails. Then only we will resort to gonadotropins. We will be giving the patient the option of either go for IVF or gonadotropins. So the problem with gonadotropins is it's not in your control. You will have you have to have strict monitoring. Suppose if she goes for OHSS and all, so that's a problem. So that's how Professor Roy Holmberg started this chronic low dose regime. So, Fesi sir, can you have
The
any
problem
experience?
with I have tried only very few patients with gonadotropin alone regime, but the total cost will go up. Total gonadotropin needed will be more compared to the sequential and chronic low dose. I think as you told, Dr. Roy Holmberg started it, and in Europe it is practically possible because the patient the treatment is part of their medical
NHS.
insurance, NHS or medical insurance. So patient will not have to bear the cost, and they don't get impatient. Here, when we give that, doctor also will get impatient, patient also will get impatient. So that is the main reason when chronic low dose and the other regime of step down protocol is that when you step down, starting with a higher dose when the follicle is 10 millimeter. If the dose is reduced, suddenly the follicle quality will come down. So whatever that all the data is that chronic low dose or at least the sequential and the step down, we have to be very careful. It will affect the result. So chronic low dose is the data is there, but the problem is that sometimes stimulation can extend up to 20 days, 30 days, or 40 days. So we have to be very careful. The cost will be too much. That is the thing we have to be. So because of that, we also don't have much experience with that. But very few patients before many years back, we have tried, gonadotropins alone. But the cost will go up. And regarding the other point, but I don't know whether you will be coming to regarding the which choice of gonadotropins you will be coming.
No, you can tell.
Okay. Also, we have tried a few patients initial times with a recombinant FSH. At that time, the about 20 years back, the HMGs preparations all were not good. Now there are good HMGs, even though it is urinary.
Highly
The
purified.
efficacy. So there is in the data also is telling there is not much difference between recombinant FSH or the urinary HMG.
So basically, now the options are there. So many options line up. Maybe before 10 years and all, not much of options. Only clomiphene was there, only gonadotropin is that. So that time, again, the chronic low dose regime was very useful. So you require a lot of patience. The patient needs patience. The doctor needs patience. So sometimes they ovulate on 21st day, sometimes they ovulate on 35th day and all. The 50% increase in the start dose is what is recommended in chronic low dose regime. So what other things you have to be is there, the practice points is again, you have to counsel them regarding the cost of intervention, that is, gonadotropin is very costly. The expertise required, you need follicular monitoring, intensive ultrasound monitoring is required. And even if you use gonadotropin alone, then the ideal thing is a low dose or a chronic low dose type of routine. That is the ideal thing. Again, what is the advantage if you ask? That is the monofollicular development and avoiding of the multiple pregnancies. That is the best thing regarding the chronic low dose type of product.
Excuse me, sir. Sir, in my practice, I have found if we counsel properly, that is, if
Yes,
we
madam.
choose the patient properly, many patients are willing for this low dose regime because it will be a synchronized monofollicular growth, and the
Yes.
success rate is also better. If they understand it, they are willing for this low dose protocols.
Okay. That's a valid point. Again, if you counsel proper and if your patient is very loyal to you and they won't jump to other practitioner, definitely you can go for chronic low dose. That has been proven many times by Dr. Roy. Okay, again, you have to think of avoiding multiple pregnancies. You have to have a strict cancellation policy. So if two follicles are more than 14 millimeters, again, you have to tell them. Again, there is a chance of multiple pregnancies there, but how will you counsel? Suppose if more than two follicles develop.
So
Panelists.
actually, initially when with the patient who is very well. She knows what is PCO and she is coming with some knowledge that is real good knowledge. Then I explained to her how these follicles are not growing in the proper way. That is, a single follicle has to grow all those physiology, a little bit of physiology. And to reach that synchronization, we need very little dose so that the other follicles will not catch up. And in case if it is more than 3 follicle, we cannot go ahead because even if she gets a triplet, let us say, all the 3 pregnancies will not be reaching maturity, and ultimately she will not take a baby home. So it's better to cancel that. Everything I'll be explaining in 1 or 2 sitting before starting the procedure, sir.
Any other opinion for
Sir,
strict cancellation policy?
Can we add up, sir? Can we?
Yes, please.
Sir, actually, if there are, madam, thank you, madam, for your enlightenment, Dr. Was, as madam had said, Dr. Sunita, madam. So, madam, if there are 3 follicles, all follicle will not get ovulate. So all the follicles, if they ovulate, all will not get this one fertilized. If all fertilized, all will not get embedded. So if there is a more follicle, I would always think in terms of having a successful pregnancy than having a triplet or a twin. So if there are more than one, I would like to tell them to continue their pregnancy because the chances of conceptions are more with the 2 follicle or with the 3 follicle. Of course, there is every possibility of having a twins or a triplet, but I will tell them to just continue it, madam. The chances of going 100% in each follicle will be quite low.
But studies have shown, sir. But the problem is, sir, the problem with multiple pregnancies, they will be happy. But the problem with twins and triplets is the morbidity associated with them, the pregnancy morbidity, the neonatal admissions, all those things you have to think. So that's why studies have proven that you have to have a strict cancellation policy. So you have to enlighten them regarding, but nowadays fetal medicine specialists are there. You have to tell that you can go for a fetal reduction also. But that's why more and more people are going for, even if you counsel, they tell that we would like to continue. But definitely the risk of preterm labor, prematurity, the incidence of preeclampsia, all the pregnancy complications are increased with the triplets and twins. Am I right? Pesi sir, Deepak?
Yeah, yes.
I think the main risk is that some cancellation policy has to be there because of hyperstimulation also. So what I usually do is that if there are more than 3 follicles, we will then counsel all definitely. More than that, instead of HCG trigger, I usually give GnRH agonist trigger and support, and we will discuss with the patient about the hyperstimulation, because when the patient has taken the gonadotropins and if you tell that okay, we are going to cancel, then it is a difficult situation. So definitely if the patient insists, we have to go for a GnRS agonist trigger. And other thing is that the incidence is less with chronic low dose protocol. So I mean, sorry, extended letrozole. So if the patient has got multiple follicles, then the next cycle we have to go for an extended letrozole. So and cautiously, especially if you are seeing multiple follicles which has very regular periods, usually add 5 days of letrozole C, and if the patient is not responding, then extend with that, and that reduces the hyperstimulation also. But definitely, if there are not exactly 3, if there is more than 5, we have to avoid any sort of trigger. But considering that three we have to be a little bit. I go for, if there is 3 or 4 follicles, I go for a GnRH agonist trigger. I like to know the other panel members' opinion about the GnRH agonist trigger. I found it to be really useful in those cases because, as Dr. Manjunath told, all the follicles will not rupture if you give GnRH agonist trigger.
I also give agonist, sir.
So I think agonist trigger is always a second option. Only the specialist, the reproductive specialist, medicine, so practicing reproductive medicine should resort to agonist trigger. And as all of you know that agonist trigger can cause luteal lysis, and you need an intensive luteal phase support. So you have to support your luteal phase with high dose progesterones if you are looking for a pregnancy.
But compared to the non-suppressed state like antagonist protocol, where the HPO axis is suppressed, that much high support is not needed for a routine ovulation induction with agonist trigger.
True. Okay. So I think the last question will be regarding IVF. I think a single statement from FESI will do the management of IVF is coupled with PCO. So he has come to you.
IVF, I think if the couple is going for IVF, definitely only antagonist protocol, agonist trigger, and free zone. That must be counseled from the beginning. And definitely, even though there is no, proper evidence of giving insulin metformin for antagonist protocol. I usually give for metformin for antagonist protocol also. I think that not larger data is not there because in those patients when we give antagonist protocol and agonist trigger, definitely hyperstimulation will be less. But I usually give metformin in antagonist protocol also, and transfer in subsequent cycle there. So definitely for that, if you are suspecting a hyperresponder, definitely you have to go for an antagonist protocol and agonist trigger has to be given. And the question of dual trigger doesn't arise much in PCOS patient. That's why I did not emphasis on the dual trigger in antagonist protocol of for PCOS patient.
So basically, IVF in PCO patients, the legendary Paul Devereaux's segmentation approach. That is, you have to go for an antagonist protocol, you have to go for an agonist trigger, you have to freeze all the embryos, and an elective single embryo transfer. So these four things will sum up the IVF in PCOS. So if you are going for this, you can avoid the dreaded complication of OHSS, and you can be patient safe. So I think that is regarding IVF. Anybody wants to add regarding IVF and PCOS? Dr. Ambali, Dr. Deepak, Sunita, Dr.
Sir, can we
I
ask
would-
a question to Madam? Madam, Ambali Madam?
Please go ahead.
Madam, do you have any experience with just puncturing the ovaries with a cold needle? Madam, you said there will be a premature ovarian failure. So nowadays, the people
Yes,
say just puncturing very deeply with a cold needle, what we use for a laparoscopy, will be doing much better than doing this one with a
Yes, sir.
needle.
Theoretically, they say the hippo pathway, which is leading to the overactivity of the hippo pathway, is what leads to this PCOS and ovulation and follicular growth. So they say even with a cold needle, theoretically, the hippo pathway disruption happens and follicular development should happen. So I don't have any personal experience with it, sir, but studies do say that it is promising. So.
But I have done many years back when in medical college practice, we have done few cases with cold needle. But the problem is that if the patient start bleeding, then that will be a problem. And the destroying the stroma won't be happening if you are using cold needle. And if you are properly selecting the patients with thick stroma, with PCOS, patients with thick stroma and bulky ovaries, definitely this needle may not be, cold needle will not be effective. But the other thing is that definitely if people are just because of scan PCOS, if you are doing, if you do the cautery, it may affect the ovarian reserve also. So if you are properly selecting, I believe we have to go for a ovarian drilling using cautery has to be done.
So
Reggie, you want
actually,
to add
I skipped this slide because
Thank you.
of this thing. These are the two things which are coming up slowly. That is transvaginal hydrolaparoscopic ovarian drilling using a cold needle, or just puncture. That is ultrasound guided transvaginal ovarian needle drilling. So just rightly told, as told by Dr. Ambali, that is you're hindering the hippo pathway, which is supposed to be the one of the postulations regarding the origin of polycystic ovarian disease. So coming to the last slide, that is for all, we have made them pregnant and all. So we made the couple pregnant, and any difference in the pregnancy regarding any particular thing you have observed during the antenatal follow-up or anything particular in PCO pregnancies, in women who have become pregnant. Yes, let's can start. Deepak can start. Deepak. Hello. Hello. Anybody online?
Hello,
Yes,
sir.
Hello.
Yeah.
Hello.
Please.
If when a
This
patient
is the
becomes
last slide.
Yes, sir. When a patient becomes pregnant, we have to always continue the metformin. Because
She will be prone for gestational diabetes, hypertension, complication, and more of miscarriage. Am I audible?
Yeah.
Hello?
Very well.
Am I audible?
Yes.
Hello?
Yes.
Hello?
Yes, you are. We can hear you.
Deepak, we can hear you.
Hello.
Transmission problem.
Okay. One of the other panelists.
Yes, sir. Sir, I would like to continue the metformin on this patient because these patients are more likely to have a gestational diabetes mellitus. So continue the gestation.
So there will be increased chance of miscarriages.
Yeah, Deepak, I think
So
your voice is breaking, so we are not able to hear you.
I think
You can close your video and talk. That will be, I think, the
video is closed.
Yeah, this is the last slide, Ajit.
Yes,
we'll be closing our panel.
Sir, we will be continuing the metformin. We never stop the metformin because it's a category B drug. It is not going to injure the pregnancy or harm the pregnancy. Meanwhile, we have to keep a watch on the liver function test as well as the renal function test. Of course, these two are the two important prerequisites before we start the metformin, but most of the people will be healthy, so they will not be having any problem. So if there is an increase in the chances of miscarriage is there, that we have to take care. And we ask them to continue the dietary modifications which we have already told them. And so look for the development of gestational diabetes mellitus. Once there is a reason, if a patient is not maintaining her blood sugar level as it should be, because we take a strict oral GGT into consideration. When we are dealing with a pregnancy, you start them on an insulin. So the insulin with the metformin should be able to take care of her blood sugar level. Of course, always look for the development of hypertension, because if there is a hypertension is a part and parcel of, because those who have some adrenal gland say 21 beta hydroxylase deficiency which manifests in the form of PCOS, we should always look into the development of the hypertension. If there is an hypertension, we should always think in terms of a preeclampsia in a pregnancy.
Thank you.
So yes, sir, starting the patient on insulin as well as on antihypertensive drugs will really help the patient to pull on the pregnancy till the term and have a delivery.
Thank you. Dr. Ambali, any one word to add
Yes.
on?
So I also feel these women, PCOS women, especially ones with clinical hyperandrogenism and high AMH levels, there are studies also to prove it that they are at a higher risk of preterm deliveries and cervical incompetence. So one single, okay, controversial, sir, but a single embryo transfer is definitely recommended, and a good NT scan and
So you would like to put surplus for all PCO pregnant?
No, sir. A cervical length monitoring might be indicated, which is generally recommended for all pregnancies as such with a level 2.
Okay. Sunita, madam?
So everything is what we do. And only thing is this IoT, of course, in selected patients, if it is, she's a very obese lady and infertility, we tend to put in stitches.
Okay. Fesi sir, last word.
I think miscarriage incidence is more, so definitely I continue the metformin if it is there for first 3 months, and then stop and then advise them to go for a GTT after 2 weeks. And if it is high, only continue it. And definitely encirclage, I don't routinely see that, but usually as the infertility patients, usually we monitor for cervical length, and if it is less, advise encirclage. And definitely that's why gestational diabetes incidence is more. That's why we had to do the GTT after stopping the metformin. And preeclampsia, I don't know about much incidence. Small for gestational age, I think there are some data. Otherwise, that's how I usually manage.
Okay, thank you, Fesi. I think with that last slide, I think we have come to the end of this discussion. Yeah.
Vijay sir, hello.
Yes, sir. Yes, Deepak.
Hello.
Yes, Deepak. Yes, Deepak. Deepak, parayu. Deepak, parayolu.
Sir, there is some problem in net connections. That is why I.
Corpoilla.
Am I audible?
Yeah.
There is some issues, net issues. That is why I missed some part.
Yeah.
Okay, thanks, sir.
Thank you very much. Thank you, Dr. Ambali Jose. Thank you, Sunita. Thank you, Fesi sir. Thank you, Deepak. Thank you, Dr. Manjunath. So I will hand over to the Master of Ceremony, Dr. Ajit, for the final concluding remarks. Ajit, over to you.
Thank you, sir. First of all, thank you to Reggie sir and all the panelists for such a wonderful panel with involvement from everyone. So many practical points in that. And thanks to Kunyumoidin sir, the president, Dr. Subhash Madhya, the Secretary General of Kfog, Dr. Suchitra Sujir, the state coordinator, and all the presidents of all the societies and all the senior members who joined in today, and to all the delegates who are logged in. Thank you. Thanks to all of them. And
Thank you.
all
Thank you.
all the best to everyone for the AKCOG and the ISAR that's coming up.
I would like to thank Ajit also. Thank you all the panelists. Thank you, FSC. Thank you, Kunyumoidin sir, Subhash. I think we almost covered all aspects of PCO. Thank you very much. Thank you.
There is
Rashmi,
one
thank you.
question, Subhash.
Thank you, sir.
Yes, FSC.
There is one question in the chat box.
Okay,
In letrozole cycle, if there is a thin endometrium, what to do? Definitely, if we have to see every 2 days if the endometrium is coming up. Maybe the follicle is not good enough. Or it may be, if you are not start monitoring by 7th day, it may be the residual cyst. Otherwise, if persistently endometrium is thin, definitely you have to rule out endometrial problem by doing the hysteroscopy. I think that was the question which I saw in the chat box.
Okay,
Yes.
thank you, FSC. Thank you. So it's almost 9 o'clock, 9:10. So thank you all. Thank you all.
Okay.
Good night. Thank you for
All
joining.
the best for
Thank
AKCOG.
you. Yeah, thank you.
Good
Hope
night.
to see you all.
Thank you.
Please come.
Sure.
Please come.
Yes, sir.
Please come. Thank you.
Thank you, sir.